Okay, let's talk about mitral regurgitation (MR). So the question is, a 23-year-old male patient with clinical complaining of fatigue, shortness of breath, occasional palpitation, echocardiography shows backflow from left ventricle to left atrium, that means mitral regurgitation during systole. Which of the following is not correct in this condition? So in mitral regurgitation, mid diastolic murmur happens, soft A happens, wide S2 happens, because if it is aortic and this is P, this is P, as blood goes from left atria to ventricle to atria, so the valve closes, this valve closes early, that's why it goes shifted like this. So wide s2 gets wide. Carotid thrill, it happens only in stenosis. Okay, mostly aortic stenosis. Here we have palpable thrill, a thrill that I don't need to hear only, I can even feel as well. Okay, let's talk about mitral stenosis. The first points are, it is the most common valvular lesion after MI. So MI, after MI, the most common lesion, valve lesion, is mitral regurgitation. In children with rheumatic heart disease or rheumatic fever, the most common valve lesion is mitral regurgitation. In infective endocarditis, I have most common lesion is mitral regurgitation. So what we see here simply the blood leaks from left atria to left ventricle due to damage of chorda tendineae. The valve prolapse, mostly associated with MR. Defective coaptation of valve causes regurgitation of blood from left atria, causes left atria enlargement. Obviously left atria বড় হয়ে যায়. Murmurs of acute and chronic mitral regurgitation are different. Acute mitral regurgitation, sudden exposure of large amount of blood to left atria leading to left-sided heart failure and requires surgery. কিন্তু ক্রনিকটা যেটা আছে ওটা adjusted, so presentation is vary. Okay, let's talk about the other parts. What are the causes? We have defined causes of acute, and the acute is obviously infective endocarditis, papillary muscle damage due to MI, bacterial infection. MI most commonly involved is posterior leaflet, mitral valve prolapse, blunt trauma to chest. This is also a reason that can cause commotiocarditis. What happens in PQRS T? In between the T if a punch is landed in between the teeth. This is the most vulnerable time for heart. If a punch landed in that very time, then the heart can go ventricular fibrillation and cause sudden cardiac death. We have an extra point here: sudden cardiac death due to blunt trauma, that is punch kick. One is commotio cordis, that is this punch landed in between T wave. That happens in kung fu or martial arts. Next is hemopericardium and acute mitral regurgitation. We can have sudden cardiac death. Next, the causes of chronic mitral regurgitation: mitral valve prolapse, rheumatic, scarring of leaflet valves. Congenital cause is cleft mitral valve, that is ostium primum. Ostium primum seen in Down syndrome, that is 21. Tripling 3x. So in chronic mitral regurgitation, what we have? We have two types of reasons. First is the valve itself. Primary is the valve itself is problematic. It happens that intrinsic damage to the valve, that is primary. Infective endocarditis, mitral valve prolapse, radiation, ostium primum, that is the ASD in Down syndrome, and rheumatic fever in child. Whereas in secondary, the valve itself has no problem, but the photo, the annular, is dilated. The photo gets dilated. Okay, that's why the blood is leaking out of the valve, because it gets dilated, so it cannot close properly. So what we have? Obviously we have dilated cardiomyopathy, the first one. It happens in alcoholics. Next is ischemic cardiomyopathy. Next is HOCM, where the in echocardiography we can see systemic anterior displacement of the mitral valve. Next is, in chronic cases, atrial fibrillation and left atrial enlargement are seen in chronic MR. Left atria gets enlarged and atrial fibrillation is seen as well. Okay, so secondary means valve is all right, but to borrow. Okay, guys. Mitral annulus calcification can result in both mitral stenosis and mitral regurgitation. SLE and RA associated with mitral stenosis, whereas spondylitis, syphilis, aortic regurgitation. Let's talk about the severity of mitral regurgitation. It is directly proportional to vena contracta. This is vena contracta, that means the narrowest part যেখান থেকে highest velocity তে blood pass করছে. Okay, so vena contracta criteria for severe mitral regurgitation. We have four things. That is, vena contracta is more than 0.7 centimeter square. Regurgitation volume is more than 60 ml. Total heart blood is pumped is 80 ml. Among that, more than 60 ml is going back in the left atria. That is, more than 60 is going back in the left atria. Regurgitation fraction is more than 50%. Normally 65% is ejection fraction, but regurgitation fraction is more than 50%. Regurgitation orifice is more than 0.4 centimeter. It is not described in the latest one, so won't remember this one. Severe mitral regurgitation is treated by preferred is mitral valve repair and superior over replacement. In acute mitral regurgitation, heart size is normal, whereas in chronic, it is getting enlarged. The left atria in chronic is actually getting enlarged. Okay, left atria. Pulmonary edema is present in most all of them, and here we have early systolic murmur where it is pan systolic murmur. We will talk about this. This is early systolic. This is pan systolic murmur. Murmur during systole only. Late systolic murmur is in case of mitral valve prolapse, ejection systolic murmur in aortic stenosis. And we have what as well? We have carotid thrill. And here we have mid systolic click. Next is the clinical features of this patient. The first one is mild moderate is well tolerated. In severe cases, we have fatigue, paroxysmal nocturnal dyspnea, orthopnea. That means supine হয়ে শুলে শ্বাসকষ্ট হয়. This patient will have 2 or 3 Balicious cushions, and he have his ankle is getting edema. Okay, ankle edema. JVP is raised. Hepatomegaly, liver is big liver. Palpitation is caused due to atrial fibrillation, and long-standing atrial fibrillation results in clots and emboli. If clots and emboli goes to brain, that can lead to stroke and may prove be fatal. On examination, the BP will be normal, but I will have a palpable thrill at apex of the palpation. That means in the on apex beat, I will have a palpable thrill. That means I can hear it and feel it with my finger as well on the apex beat. I can feel this. Hyperdynamic character of apex beat, that means displacement of apex beat because heart getting bigger. So both of this can be seen. Along with that, hepatomegaly will be seen. Bilateral ankle pitting edema. On auscultation, as the heart getting bigger and I have MR, so the S1 will be soft. How to remember that? In mitral stenosis, let's talk. In mitral regurgitation, as there is simply a leakage. It is getting as there is simply a leakage, so blood will come out. So the dorja is not getting shut very strongly, so S1 will be soft in MR, whereas in MS, mitral stenosis, the blood is coming from a very narrow part, so it will be hard, louder. So loud S1. Just remember this, mitral stenosis, loud, sound is loud, sound loud. S2, that means this part. As some part of the blood is going this side and the remaining is going this side, in 80 ml around 60 ml is going this side, so only 20 ml is coming from aortic. So in S2, that means A2 P2, this is P2. P2 is dancing this little bit with inspiration and expiration. A2, only 20 ml blood is coming from this door, so it will close soon, so it is shifted this side. So I have a wide S2 in mitral regurgitation. I can also, that is written here, I can also see S3 diastolic murmur heart, that is mid diastolic murmur. What is this? How many types of murmur already we have seen? We have, just write S1, S2, S1. In aortic stenosis, what we have? In aortic stenosis, we have ejection systolic murmur. That means this goes up, then comes down, comes down, comes down, comes down, comes down, comes down, comes down. So this is in aortic stenosis, ejection systolic murmur, that is crescendo, decrescendo. Okay, and it comes with the keyword is carotid thrill. Okay, stenosis means the valve is getting smaller. It is closed. This aortic valve is getting smaller, so this happens. Okay. Next is mitral valve prolapse. Mitral valve prolapse means I have, this is my this is my tricuspid valve, this is my mitral valve. Now when the systole occurs, here normally blood goes from this, here the mitral valve goes up like this, much more, and it gives, because of this stretching, there is a phat করে একটা আওয়াজ আসে, so that is the mid systolic click. This is S2, this is S1. So this part is systole, this is diastole. In the middle I have a mid systolic click, because of the chorda tendinous, and then I have a murmur like this. Okay, this is late systolic crescendo, decrescendo murmur. Alright, next comes my topic of interest of today. S1, S2, S1, S1, S2. Now I have two scenarios. One is chronic mitral regurgitation. In chronic mitral regurgitation, the adaptation is better. So the throughout this entire systole, I have a murmur entirely, entire systole only. S1 to S2 is the systole. This is the pan systolic murmur, and then in this diastolic phase I have a mid diastolic murmur, that is this. Okay, this is a mid diastolic. Only seen in this particular case, that is chronic MR. It is also known as flow murmur. Then comes acute mitral regurgitation in MI, in rheumatic heart fever, in endocarditis, infective endocarditis. All of this, I have an early systolic murmur. This is the systole part, and I have this murmur only for this part. So here I have a in infective endocarditis and all, I have a early, then it is systolic murmur, early systolic murmur. Okay, only in chronic mitral regurgitation I have flow murmur in this part. This pansystolic murmur can radiates to axilla. Okay, pansystolic murmur in apex radiates to axilla or back, মানে বুক থেকে পিঠের দিকে যায়। Okay, now this is the auscultatory finding, that is in sound S3 is present, and that is the mid diastolic murmur or diastolic murmur simply. Okay, let's talk about the ECG. In the ECG, we see a notch. This notch is present in mitral regurgitation, along with P mitral is more than 120 second. Sorry, 120 millisecond. What does it mean? P pulmonal notch is present and a vertical height is increased. Duration of P wave is actually more than 120 second. It means simply duration. This duration is more than 120 second. And more P wave means the left atria getting enlarged. That means left axis deviation is seen. If it is the left atria is this, now getting like this sized, and this is called a double atrial shadow or double atrial contour. This is a PYQ question. In cardio, in X-ray, what we see, cardiothoracic ratio increased because of cardiomegaly. Simply heart is getting enlarged. Okay, normal is 60 to 70 degree, and next is cardial angle. What is this? This is the angle. That means if it is the trachea, and this is the angle. Normally it is 60 to 70 degrees normal, and here it is more than 70 degrees. That is walking man sign. Okay, So this is the walking man sign. Important PYQ. Investigation of choice is transthoracic echocardiography, that is ECHO. Now we can see pulmonary edema as well, mid pulmonary congestion with peripheral shadow because of the pulmonary edema. In case of acute mitral regurgitation, pink frothy fluid is not seen, whatever. Now the treatment, acute MR. We have two treatments for acute MR. We give furosemide for decongestion, শ্বাসকষ্ট হচ্ছে যেটা সেটার জন্য, তো ব্লাড ফর decongestion, pulmonary edema, that means শ্বাসকষ্ট দূর করতে। Next is sodium nitroprusside, that is a powerful vasodilator. This powerful vasodilator is used for decrease the load of heart. Has so much extra is written, not necessary. Simple, decrease the load of cardiac load. Next is chronic mitral regurgitation. We have two things. One is MVRP, that is mitral valve repair, or MVR, that is mitral valve replacement. And next is these things are not required anymore. These things are not required as well, because this is done mostly. Mitral clip, that is transcatheter mitral valve clip, that removes the damaged mitral valve tissue, and mitral valve squeeze the valve. Mitral clip squeeze the valve and valve leaflets function appropriately. Okay, now some extra information, that is the atrial fibrillation. It is seen in cases of mitral regurgitation. Structural damage to left atria, clot formation, predisposes to embolism, cerebral embolism, and risk of stroke is more. Now, in case of atrial fibrillation, I have seen in many things. If it is rheumatic fever, and atrial fibrillation is occur, because of this atrial fibrillation, what happens, the left atria, if it is heart, the left atria gets damaged, so clot formation happens, and this clot can go to brain and cause stroke. To reduce the stroke risk, in rheumatic fever, to reduce risk of stroke, we give warfarin, that is oral anticoagulant. But atrial fibrillation due to mitral valve prolapse, we have to give, to reduce the risk of stroke, we give novel oral anticoagulant, that is apixaban. It is contraindicated in atrial fibrillation due to mitral stenosis due to rheumatic heart disease, that is rheumatic fever, and in metallic prosthetic heart valve. So this is the entire chapter.